Hey, Doc.
Hello. There we go. All right.
Hey, April. Hey,
Hey,
Gary.
how's it going?
Hey, Dr. Hartman. I'm Gary McGibney.
You know, Gary, I guess you don't remember me. We did
I do remember you.
presentation together on school climate 2 or 3 years ago. I don't know. It's been a while.
Of course I remember you. I just didn't think you would remember me.
I remember you. I was very impressed with it got me very interested in school climates and a lot more involved in the school-based health clinics.
Well, great. That's good to hear. That was fun to do, wasn't it?
It was.
How have you been?
Busy. We're going through a partnership with Wellstar, so never a dull moment.
Yeah, I heard about that. It's all good though, right?
It's good. I think it's going to definitely make things better.
And there's one of my heroes, Lizanne. How are you?
I'm doing well. I'm actually in Atlanta. How about that?
I can't believe it.
I'm at the Atlanta Fed.
Oh, okay. Well, can you tell them to work on the interest rate a little bit?
I'll pass that along.
Maybe if they could lower it a little bit.
Well, be careful though. You got to be specific because they may raise it if you don't tell them.
Good point. Hi, Ashley.
Hi, Ariane and Emily.
Hi,
everyone.
Hi, everyone.
Hi, good
Thank you,
afternoon.
Thank you, Ashley, for all you do setting these up.
Of course.
Yes, thank you. Good to see everybody. And thank you for having us. So getting us on the agenda so quickly, Dr. McGivney and Dr. Lukowitz. We're thrilled. And good to see you, Dr. Hartman. I haven't seen you yet this week, have I?
No, and I was supposed to call you one of these evenings and things got crazy. So we'll connect soon.
Sounds good.
We've got a few minutes. We got a rather ambitious agenda today, but that's good for everyone. Is there anyone that absolutely needs to leave early? Because we have a sort of an order right now, but if there's someone that needs to go before that, we can arrange that.
I'm great with the order. The only thing is right at 5:30, I have to talk to a reporter about a publication that just came out. So I have to jump off right at 5:30, but that's it.
Okay, well, we should be done with your part by then, so you should be free to go. And I think that Ariane and Lizanne can probably handle any questions when in your absence, right? I'd like them on my team as well.
Lizanne is the headmaster implementer extraordinaire of Handle with Care. So she can answer much more than I can.
Wow. No, we're very excited. Well, welcome, Miriam.
Good afternoon. How are you doing?
I'm well, thank you. Dr. Bradley and Patty, welcome.
Hey there, it's just me. Patty shows up on my list, but it's just me.
Okay. You just need her name there for company, right?
It does. She gives me all my support.
I'm sure. I have no doubt about that.
Hello, Dr. Vall. We met through the Athens Area Foundation with Sarah.
Yes, nice to see you. How have you been?
It's sort of amazing how people make connections. I mean, there's a lot of people that I've met in other settings that are going to be presenting today, and it's just very exciting to see that. Now, Ariane, I think, should bear responsibility for introducing me to half the people I've met. So I always call her the matchmaker. But
Happy to introduce you to more people.
I've got someone who's dying to meet you, but we'll have to figure out how to do that still. So. Okay, well, we've sort of hit 4 o'clock. And we've got, like I said, a rather ambitious agenda. And I think that we should go ahead and get started. We've got sort of a varying, slightly different focus today. It's a lot of different areas. So let's start off with my friend, Dr. April Hartman, and colleague here at the Wellstar MCG Health System. And she's the Vice Chair for Diversity, Equity. Oh, now it's about to change, but for now it's still that, right, officially. So anyways, and she's Associate Professor in the Department of Pediatrics and Adolescent Medicine here at the Medical College. So April, the floor is yours.
All right, I'm gonna see if I can share my screen here. All right, can you guys see my screen? Yes. All right. So what I'm here to do today is kind of just give you a view of mental health and the impact that it's having from the perspective of a general pediatrician. I am a general pediatrician. I see some of everything, but I primarily have started to do more behavioral health for many different reasons, but mostly just because it's such a problem. So today I just kind of want to give you an overview of what it looks like from my boots on the ground perspective, some successes that we've seen that I think we can celebrate, some of the barriers and challenges that still exist, and then a few recommendations. I'm going to go kind of fast, but at the end, if you have questions, I'm more than happy to answer any questions. So one thing about general peds is things have really shifted for us. I trained about 25 years ago, and at that time, we mostly learned infectious diseases, you know, how to treat meningitis, how to treat pneumonias, all these things. But the widespread use of vaccines has essentially eliminated a lot of these diseases. And so general pediatrics has become about development and behavior. That's what we do. That's the bread and butter of our services. That's what we talk about with everybody at all ages. And so it's a big, huge part of what we do. The problem has been that training us has been a lot slower in training us in this shift. So there's still a lot of training on infectious diseases and all these things. And not so much the training that we need for behavioral health, which has led to a lot of physicians feeling uncomfortable or just having a hard time with treating the things that we see around mental and behavioral health in children. This also, you know, we know that there's a problem with specialists, right? We refer them because we're uncomfortable sometimes in treating them. And so they then have to wait a long time, 6 to 18 months for a lot of areas. Sometimes there's not a provider in that area at all. And so you can see that there's just a workforce shortage. We're aware of that. The thing also that is really hard for us as pediatricians is that these problems are being identified at younger and younger ages. So whereas we used to deal with this stuff in teens, and we were really happy to send them to the adolescent medicine doctor, but you know, now we're screening 8-year-olds. We're required to screen 8-year-olds for anxiety. And we're seeing ADHD being diagnosed in kids that are 3 years old. And so there's really a shift in the ages. That creates a big problem because a lot of the psychotropic medications that we use are not, there's no guidance on how to use them in children this young. And so there's a lot of what we call off-label use of these medications because the research and stuff that says this is definitely what you should use in this age is just not there. And so there's some hesitation in treating this because we don't know what the long-term effects are on growth and development. You know, when we use Abilify in that 11-year-old right before they start puberty, does it affect their growth? You know, we don't have a lot of really good data on these things. And so some pediatricians just have a really hard time prescribing because we just don't know what those long-term consequences are going to be. And then there's also just the fact that, you know, if I screen for something, but I don't have any resource to address it, should I even screen for it? And so a lot of people are resistant in screening for these things and catching them early because the resources are just lacking. So, you know, the thing is, we are seeing these kids, so we have to respond. So what have we done? A lot of what we do is around prevention. Pediatricians, and if you guys have kids and you've taken them to the doctor, you know that we ask a bunch of questions. We want to know what's going on at home. Does that kid have a safe place to go? Is there any problems with food? Do you have enough food to make it to the end of the month? We ask all these questions. We do these screenings, and they're required if we're going to bill for a well child visit. We've been educating ourselves. There are a lot of training programs that you can go through that better prepare you and help make you feel more comfortable with treating these behavioral health problems. And so there are many programs, echoes, webinars, podcasts, everything, so that you can learn and provide these services within primary care as much as possible. And then we collaborate. We try to reach out to our community behavioral health centers here in Augusta. That's Serenity. We were sending patients there. They were saying that, oh, we hate going there because we're in the waiting room with adults and it doesn't feel safe because some of those adults may be saying things and acting in a way that makes it threatening. We reached out to them, talked to them. Now there's a separate waiting room for children and adults. And so now we can feel better about sending everything. So these type of collaborations, we're starting more school-based clinics, which is great. And then using telehealth where we can has been a great thing. But the thing that has helped more than anything else is integrating behavioral health into the primary care setting. When there is a behavioral health provider right in that primary care office, you recognize something, you can say, hey, you know, I think you need some help with this. Let me bring in so-and-so, and you can bring that person and do that warm handoff and talk to them right there. And that has helped, that helps tremendously also. So the state, like I said, there's some things that we can celebrate. 988 has been great. We promote it all the time. We tell people that instead of going to the ED, get the mobile crisis unit to come. I've had people who have told me we did this and it worked and it helped and it was good. They're able to text or chat, and now that's available in Spanish also. So that's been a great success, and I hope that we continue to expand that. There's parity, or at least in theory, there's parity, right? There's some issues with it going out, but still it has made a difference. It has increased the reimbursement that we're seeing in response to what we're doing. There's been some increased funding for school-based centers. Governor Kemp put aside the $25 million. They're going through a second grant cycle now. That's been great. There's more funding for the community-based health centers. These things are all good. We're expanding our workforce by broadening who can provide therapy and reimbursing for social workers. Apex has put counselors in the school system. All these things have been great. We're starting GMAP is starting to take effect, and that is an access line. All these things are successes. And then there's a lot of increased focus and attention on finding ways to address these problems. There's so many organizations and professional societies and others who are working to address the mental health problem. And it's been great, and it's been very helpful for us as pediatricians. Some of the barriers, these resources aren't always distributed equally across the state. Sometimes we get frustrated because we say there's a Georgia outside of Atlanta. And we need some more resources in the areas outside of Atlanta. When you look at this map by Georgia Voices, you can see the gray areas, it's actually where they do have resources. And so the Atlanta area is a big area where there's more resources than they are in other areas. The dark blue is where there's no resources at all for behavioral health. And so this is a big problem, and we need these resources to be distributed more equitably throughout the state. Technology is an issue. We love that you can do telehealth. The problem with that is that in the rural areas or in some of the underserved areas, the connectivity is not good. It drops. You can be having a visit with someone and it'll just drop the call. But also the people who have to access this virtual visit don't always have the savvy to know how to navigate this technology. I had one grandparent who now has custody of their 3 kids ask me what she could do. And I said, oh, we can do a virtual visit. All you have to do is download the app. And she asked me, she said, what's an app? So there's some of this technology that the people who need it most and need access to this just aren't able to make use of it. And so there's disparities because of that. When we talk about insurance, it's a big thing because there's a lot of people who say that they're taking Medicaid, but when the patients call and talk to them, they're not taking it or they might take one, but not another. And it's really hard to get them in with someone. Medications are a big deal because some are covered, some aren't. There's all these administrative burdens that are put on us. You know, like we want to prescribe something that we think might help, but we have to get a prior authorization. And then it may still be denied because we didn't go through the steps they wanted us to go through first. There may be an age restriction. There's just a lot of administrative burdens that are placed on practices to try to help the patients that we're trying to help. When we talk about the formulary, it is a nightmare because every managed Medicaid, and we have 3 right now, they have a different formulary. So if I prescribe something to a child while they're on Amerigroup and then they get shifted over to Peach State, I don't care if they've been on that medication for 2 years and been doing great. If they switch over and that medication is not on Amerigroup's formulary or Peach State's formulary, I have to start all over with a different medication and going through all the steps to get them what they need. Liquid and chewable formulations are often just excluded, or they may have an age restriction. But when I have an autistic child that's 11 years old and can't swallow a pill, I need that liquid or chewable option for them. And a lot of times it's just not available. The parents have to crush the meds. We don't know what they're crushing it in or how they're crushing it. And if it's all being given, it just creates a bunch of problems. A lot of times the payers are reporting that they're doing these things, and some of the providers are saying, oh yeah, we take Medicaid, or, you know, but what that means is they'll test, but they don't provide therapy, or they do the intake, which is the highest reimbursement, but then they put them on a wait list for therapy, which may be 6 or 9 months later. So they can check the box saying, oh yeah, we got them in within 2 weeks, but what has got them in? What does that mean? So for us, we're so happy because they have an appointment, but then the parents come back and we're like, are you going to your therapy? Oh, we're on the waiting list. And so then it comes back on us again to try to help them. The other thing is when we tell them, most mental health providers don't want us to make the appointment. They want the patient to call and schedule. And so we give them a list and they call and they're like, oh, I called all 10 of these people on this list and none of them are taking my insurance anymore. So again, lots of problems around that. So what can we do, right? What are the recommendations? Definitely continue what we're doing because we have made some strides and we have been successful in a lot of ways. We need GMAP to be expanded. We need to have an access line that we can call, and because a lot of times as a pediatrician, I've had some training, I can handle it. It's just the most complex that I need to refer. So if I could, sometimes I don't even have to refer them. If I could just call and ask and say, hey, I have this kid who's on this, and this, and I want to wean this, I want to take them off this medication. What's the best way to do that? If I could just get an answer to that, I wouldn't have to refer them at all. We need to continue the increased coverage and reimbursement for mental health conditions, and continue funding and supporting the school-based centers, because if we can catch kids at school where they are most of the time, we're going to be way more successful. We've got to have integrated behavioral health. This is the setting that has the best outcomes, when I can just do that warm handoff, have someone right there that can start that relationship at the time the patient's there. That's great. There are codes that cover this type of team-based care. These are not reimbursed in the state of Georgia. We've got to change that. We want to do this. We could do this in the school-based clinics by collaborating with that Apex counselor that's there to provide that warm handoff. We could work with the school nurse. We could have an automatic integrated clinic right there in the school system, but we have to be able to sustain and get that reimbursement. And that means getting these codes to be covered codes in our state. We also need to encourage different agencies that employ behavioral mental health specialists to offer those specialists to primary care practices. Let's embed them instead of setting up separate centers where we're separating, oh, here's where you go for your mental health, here's where you go for your physical health. Let's put them together. And let's get rid of some of that stigmata of going to that mental health clinic. Oh, you're going to the psych place or whatever. Let's get rid of that by just putting that in the primary care setting where they go and where they trust us already. And we've got to have some communication. Like I said, when we refer someone to a behavioral health provider, most of the time we have to just tell the patient, here's the number, call and make an appointment. We don't hear anything else. Did they go? Did they get a diagnosis? Were they started on some medication? We don't know. We're totally reliant on that parent to come tell us. And then the parent will come to, oh, they started them on 3 different medicines, the little blue pill, and then the capsule that they take in the morning, and then that thing that they take at night. Well, what is that? How do I know? So also we need pharmacies to go back to putting brand names on the bottle. That parent can't tell me that they take dexmethylphenidate and they take, clonidine or whatever. They can tell me, oh, I take Focalin and I take, they can tell me the brand name. They can pronounce that, they can discuss that, but that's not on the bottle anymore. All we're seeing is generics, so the patients can't tell you even what they're taking. And then the other thing is not all generics are equal. So if they tell me they're taking methylphenidate, I don't know, are they taking an extended release? Are they taking the short acting? Are they taking something that releases 30% quickly and then the other 70%? Or are they taking something that releases 50% and then the other 50% is delayed? I have no idea, often just by that one word or what they're calling it, if they can pronounce it, to even know what they're taking and be able to adequately address the needs that they have. So something as simple as getting pharmacies to put the brand names on there would be so helpful. And then we just need more investment in the collaborations and coalitions that are doing this work in the community, on the ground, helping develop these programs that are so supportive of kids with mental health problems. Of course, we would like stricter requirements, make them more accountable, make them build out their networks. But right now, while we're going through the RFP for the new CMOs for Georgia, this is the ideal time to say, hey, how about establishing a common formulary for behavioral health conditions? So that it doesn't matter which insurance they're on, we have the same formulary that we work from. They can stay on their medication once they've been established on that. It's known what they're taking. It is a common, this is something that we would be so helpful, because now instead of thinking, okay, you have a peach state, so I have to give you this. Oh, you have Blue Cross Blue Shield, so I can only prescribe this. Oh, you have, it's one formulary. If we had one formulary, that would help so much. We need to be able to have liquid and chewable formulations for the kids. Like, they're available. We need them on the formulary so that we can use them. And then we need to not have so many administrative barriers to getting these things. If we are diagnosing it, if we're using this medication, we don't need to jump through 15 different hoops to get it. The other thing is, it's super hard, or it takes months and months to enroll a new provider so that they can get reimbursed through Medicaid. We got to fix that. When you look on paper, it says that within 30 days, you'll be enrolled, or you'll get a number where you can start providing services, but it doesn't happen that way. And that accountability of making it a timely process is becoming more and more painful. So even when we do get a new provider, we're able to recruit a new person. It takes forever to get them to be able to get where they can get reimbursed. And then, my dream, like I always have to put one dream big thing on here. My dream big thing would be that for school-based services, that we could be enrolled at a district or regional level, so that we could go to several different schools. Some of the more rural schools don't need a pediatrician there every day, but if they had someone every Monday, and then I went somewhere else for another, for every Tuesday or Wednesday, we have people who are willing to provide those kind of services, but there's not a streamlined way or an efficient way to make that happen. And so if I had one dream, it would be that as a pediatrician, I could be enrolled with a district or a region, or even at the state level, to provide school-based health services, and that I could do that, in rural and underserved areas. It doesn't even have to be in the areas where there's lots of pediatricians. I'm not trying to take anyone's business, but I would love to be able to go to areas where there's no one and provide those services. And that's it for me. That in a nutshell, or maybe not nutshell, gives you plenty to think about, and just kind of my perspective and what I'm hearing from the pediatricians that I work with. I also serve as the chair of the Medicaid task force for the Georgia AAP. So we hear lots of comments on Medicaid and the difficulties that providers are facing. So if you have any questions, I think I stayed within my time pretty good, but I can answer any questions that people may have.
Dr. Hartman, thank you for this. This is music to my ears, and not something that we've not heard of before. So the unified formulary was something that we recommended in the first year of this commission. And it actually was in a bill in some form, and there was actually a formulary devised, but I don't know what's happened to it. Even the Department of Community Health and regular Medicaid is not using it. So this is a absolute necessity.
So it was not an actual formulary. What it was a list of all the medications they had in common. So it wasn't like they collaborated to form one formulary. They just said, oh, here's the 6 or 10 things that we all have on our formulary. This is your common formulary. These are the things that are on every one.
Yeah, we need that, and it needs to be much more inclusive than it is, because what I've noticed is that less and less medicines are appearing on the formulary, and some of them just don't work. So that's really important. And I agree absolutely that the integrated behavioral health is the best way. And myself and my colleague, Dr. Peoples, both spent time in a pediatrician's office at some point in our careers and found it to be just a wonderful way to go about business. But we were told at the time, well, this is not working financially. So hopefully we can figure that out. And then the other thing, which generic medicine, this is a bugaboo of mine. One of the things that's not readily made available is that generics are not identical to the brand name. And the way it stands right now, in order to be considered bioequivalent, you can have anywhere from 80 to 120% of the bioequivalence of the brand name. And so if you happen to have one that has 80% one time, and then your pharmacy switches to another generic, which has 125%, you're like getting 50% more medicine, which is going to have cause problems. So anything that needs to be very tightly regulated, like lithium, for example, is one that probably you need to be careful about prescribing generically. And thyroid hormone is another perfect example. So I think this is wonderful, and really appreciate your presentation. Other questions, comments?
I just wanted to comment on a personal note. I am a foster parent of 2 children that are very young, and I feel like you hit the nail on the head with everything we have experienced with Medicaid and getting services for our children, medications, the hoops and the waiting list to get those services. And so it's just really nice to hear that is something that other people know, and hopefully is something that can be worked on and improved.
All right, well, let's since we do have a rather ambitious agenda, let's move on with our next group, handle with care. And Emily, do you want to take the lead, or do you have another plan?
No, yep, I will share slides if that works for you, Lizanne, and then you can just tell me when to skip and I will. So Dr. Hartman, I just, and all of you that are physicians, I just want to say thank you for what you do. I saw what you're talking about in action in the ER a couple of weeks ago, and it's one thing to hear you testify, but when you see it in real life, what's happening, it's just heart-wrenching. So I'm very excited to talk a little bit about Handle with Care with you today. I wanted to give you a little bit of background about Resilient Georgia. I'm the executive director of Resilient Georgia, because it provides a lot of context about how we came up with this recommendation and why we're so passionate about this program. So we are an organization, we just turned 4 this year. We're a statewide coalition. We have over 900 different partners and stakeholders at the table. Once we got going in year 1, we created this effective collective impact model, and our mission is there on the screen, but we're very committed to building a more resilient, trauma-informed Georgia by preventing ACEs, and our end goal is to create an integrated behavioral health care system for the state of Georgia. So once we identified all these big points and we knew where we were going, what our North Star was, and that our model was effective, we began to build out 3 pillars of work. And then from there we franchised, which I will explain in just a moment. So we pride ourselves on convening and connecting. We do that in many different ways. Sometimes it's an individual introduction. Sometimes it's an organizational introduction. Sometimes it's from philanthropy to folks on the ground doing the work. That looks a lot of different ways. We also celebrate and share innovation. We do that through, we have general meetings. We have a lot of different communication tools that we use. And then the third way is to remove barriers. And we do that in a macro and micro ways. So things like throwing as much weight as we can behind different important pieces of legislation, helping to support the Behavioral Health Commission in different ways, and then also just removing introductions that are a little bit, or removing barriers through introductions and getting folks in the doors of various organizations or whatnot. So once we identified all this framework and how we were working, we started to basically franchise. And now we are happy to share, we have 16 different regional coalitions that work at the regional and local level across the state. And the way this works is we identify, oops, oh no, sorry. I'm so sorry. I moved my screen. Oops. My apologies. I moved my keyboard and that was a mistake. I will not do that again. Anyway, we got this model underway. We replicated it across 16 different regional coalitions. And the way this works is we link philanthropic dollars to the regional leads, and we help provide technical assistance to build out 2-year action plans with the different regional coalitions. So all the regions look drastically different. One thing that comes up a lot is we have a lot of trainings that are in common. And so we share different training opportunities from region to region. And we also have a few different programmatic lifts that have worked in many different regions. One of them being Handle with Care, which Lizanne, who is down here in Chatham, Effingham, and Bryant County, is going to share with you. So we also work with a lot of statewide partners, including the Georgia Center for Child Advocacy, the Georgia Family Connection Partnership. Sorry, I did it again. And the Criminal Justice Coordinating Council. So through those particular partnerships, we've gone after a couple different applications for Handle with Care. The Georgia Center for Child Advocacy created this slide, and it just showcases all of the different areas across our state that are either working to implement Handle with Care, are interested, or are discussing it. So now that you have a little bit of context for who we are, how this conversation has formed, what's going on in the state, I'm going to give the microphone over to Lizanne so she can talk you through a little bit more about what Handle with Care is and why it's such an effective model.
Good afternoon, everyone. Thank you for the opportunity to present. So this is a flow chart of how Handle with Care works. So when a child's exposed to a traumatic event, a first responder, law enforcement, EMS, or fire might be on scene. They observe the child. They do a Handle with Care referral. There are only really 4 pieces of information that are shared in that referral: the child's name, their approximate age, the school that they attend, and the words Handle with Care. That transmission goes to the school system. They pick it up. It's usually in the social services area of the school or the school counseling area. There's one particular group that's usually responsible for picking up that notice. And then they notify the school and the homeroom teacher or the teachers that are interfacing with the child or young person that day. They observe the child, and if they start to exhibit behaviors, they get them to a school counselor or get them to the needed supports that they may need during that time. If they don't observe any behaviors that might need some extra care, they just observe and continue with regular class activity. Next slide. So this is a more simplified version of what this looks like. So the school district contact receives the Handle with Care notice from law enforcement or other first responders. The school contact informs appropriate teachers and school staff. And then teachers and school staff observe the student to determine whether the student needs additional supports and offer the appropriate trauma-sensitive supports as needed. This model was founded in West Virginia at the height of the opioid crisis. And it's now was actually part of the West Virginia Defending Children initiative. Next slide. So this is about approaching children with challenging behaviors through a lens of compassion instead of punishment. Next slide. So in Chatham, we developed this QR code to make it simple for a first responder to make a handle with care notification. The form, I'll talk a little bit more about that, was developed by the school system. But the handle with care children supports children exposed to trauma and violence through improved communication between first responders and schools. And it promotes partnerships that ensure children who are exposed to trauma receive the appropriate care and interventions to help them achieve academically. Next slide. So implementation in Georgia. So Judge Key led the development of Handle with Care in Georgia as the first county to implement this systems change. He was the first person that I called. I learned about Handle with Care at a conference about opioid abuse prevention. And the assistant chief and I, who were in this session, both looked at each other and said, we've got to do this in Georgia. It's important for us to do that. That was right before the pandemic happened. And so it took us a bit of time to get through to a place that we could implement, but that was needed time that we took advantage of to really develop the partnerships that we needed to make it successful. So it was launched in 2021 through a partnership by Savannah Police and the Savannah Chatham Public School System. We now have 5 jurisdictions, our largest EMS provider and 2 fire departments that are a part of the Handle with Care initiative. Next slide. Nationally, there are 24 states that are implementing Handle with Care at the state level, including 6 southern states, Florida, Kentucky, Maryland, Tennessee, Virginia, and West Virginia is the state that's had the longest running Handle with Care program statewide. I'll tell you that, or share with you that as we have implemented Handle with Care in our county, I've had calls from all over our state about how we implemented it and how it might fit in other, both smaller and larger counties in our state. So we have a groundswell of counties that have great interest in moving towards this systems change to develop these partnerships between law enforcement or first responders and the school system. And I will tell you overwhelmingly that police, fire, and EMS really like this opportunity that they have when they're on scene to do something that or take an action that's going to help a child. Prior to this, if it met the threshold of Child Protective Services, of course, they're going, as a mandated reporter, going to file a report. But quite often, they may be in situations where it doesn't hit that threshold. And this is an opportunity for them to take a positive action that's going to help a child or young person. Next. So you want to take it back over, Emily? Can't hear you.
Thank you. So I'm sorry, it's late in the day. I'm a mess today. At this point, over our last 4 years, we've had hundreds of conversations about Handle with Care, both with partners that are actively implementing, with interest in so many of the counties that I showed you on the map, and with leaders like Lizanne, Ariane, Tiffany at the Georgia Center for Child Advocacy, and Alex, and all these different partners that are very engaged in bringing it to Georgia. So we really wanted to share with your subcommittee that we feel as a state that we're ready to roll this out statewide. But there are a few resources that we feel are needed. So like I mentioned a little bit earlier, we do have a full application that we've drafted. So we've got all the language in place. Unfortunately, for that grant, it was not funded, but we have a lot of good language. The plan includes a multidisciplinary expert advisory panel, 2 full-time FTEs to be housed at the Georgia Center for Child Advocacy, a mini grant implementation program that would provide school districts and/or schools with mini grants to get the program up and rolling in their schools and with their precinct or first responders in their community. Training and communication plan build out, and data and evaluation plan build out. So the annual cost would be between $400,000 and $450,000 per year. And again, that includes 2 FTEs that we as a group came up with the idea that they probably should be housed at the Georgia Center for Child Advocacy because they have both the statewide reach and the capacity to house those positions and manage everything. And then the mini grant program and administrative costs. When we've had all these conversations, we've really understood from hearing from everybody that there needs to be that top level convener and connecting all the pieces, because even with the map that we showed you, we know that there's other areas in the state that are having these conversations that we haven't yet spoken to or talked to, and that are rolling this out that could do so a lot easier with the statewide collective at work behind it. Thank you very much for listening to us, and we're happy to answer any questions about the program or about implementation or anything else.
Dr. Veld or Emily, do you know how many school districts are implementing Handle with Care?
At the district level, I would have to look it up. There are definitely several. I don't know, Lizanne, do you have a better answer?
Just in our Region 12 area for Family Connections, we have 5 counties in the southern region that are implementing Handle with Care. Others are having conversations about implementation or starting to work towards that. But there are, I was on a call a couple of weeks ago with Gwinnett County. So they're in the process of moving towards implementation. So we've got, I would say, I think I've met with Hall County. So there are counties all over the state that have started working towards this. I think we've got probably, if I had to ballpark it, we probably have around 15 that have fully implemented. And then, we've got a lot more that are in that stage of working through the processes to put the system in place, working through the MOU process with first responding agencies, developing how they're going to collect the data and make sure that they have the fidelity of the model in mind, because the fidelity of the model is paramount to how it works. You'll notice that I said there were 4 pieces of information: child's name, age, the school they attend, and Handle with Care, and that's it. The data is not shared broadly within the system that collects it. And so we want to make sure that as we roll it out statewide, that we have people in place that can help systems have that model of fidelity.
And the other piece that gets a little tricky is with the larger school districts, when you have, 23 police precincts, you have to go through all of them to get your MOUs in place. And so it starts to snowball into a pretty large program and project for the larger districts.
Right, that was my next question, because it doesn't really even have to be a large district to have multiple jurisdictions within a county. So, but you have a method for working through multiple MOUs.
We have a lot of experience now with Lizanne and others. And the nice thing is we have school districts that are, some of the most rural in the state, and then we have some suburban and we have some urban. So it's a nice diverse group where we can pull and learn from each other.
So I never cease to be amazed that whenever something new and innovative is going on in Georgia, it always seems to happen in Chatham or County or Savannah. What is your secret?
We are a community of coalitions. So we have built very strong coalitions within our community and have made it common practice to work together. It's now uncommon for us not to pull people together and figure out how we're going to affect change. It's usually the other way around. We're usually convening and really working together to move initiatives forward. We also have a governing document in Chatham called the Chatham Community Blueprint. And that's housed at I'm the Family Connection Partnership in Chatham, but I'm also a nonprofit. So we house that document at our nonprofit. Dr. Hartman raised her hand.
I just wanted to say that as a primary care provider, I would love to know when one of those handle with care notices happen, because a lot of times they don't go to school the next day, they come and see us. And it would be really helpful, to know that.
Absolutely. I would add one more thing about Savannah is they come up with some of the most innovative ideas. So if you're around the area, I think it's this weekend, right, Lizanne? They're hosting a mental health car show. So lots of fun, different ways to get people that wouldn't normally be engaged with mental and behavioral health engaged.
So the other piece that I would say is that we're a good size city to do the collaborative work. So, we're sort of a mid-sized city. So that's another part of the story of the work. And then the other piece is I get to work with wonderful people like Ariane, who when she calls me, I usually answer. Because she usually has something good up that she's bringing forward.
Does she tell you, I have someone that I want you to meet?
No.
Oh, she's always doing that to me, so I always answer as well. But
yeah, she usually says, "Well, I've got this great program that we're thinking about doing. What do you think about that?" But I really, it's so good for what has happened in Chatham. The story there is that the school system loves it. They like it because it gives them not a lot of information, because we're not sharing what happened on scene. We're just sharing that something happened. And then they have that opportunity to change how they might respond to a child who might be in distress. And then the other piece, really, I can't say enough about how law enforcement and first responders have embraced this. So as a note, we had in August, we had 43 referrals in 1 month. I'm not happy to say that, because those are all children that needed care. The good news is that they probably got the care that they needed at school. And thank you.
well, as part of my training, I had the opportunity to spend time at the Kemp Center for Abused and Neglected Children. And it was not hard to identify the problem. The problem was getting the message out to people around. So this program sort of fits right in and takes care of that, which takes care of the schools. And if we can include the primary care physicians, it's like a solution to a lot of different problems. So it's just a really well thought out and needed intervention. So I really appreciate your presentation today.
And
Okay.
Dr. Hartman, that's an interesting, very interesting point, Dr. Vell and Lizanne. Would it be feasible to add the contact with a primary care physician?
I don't know what it would look like, but I think it's reasonable. And I don't know as another state has ever had that conversation, but I think between BHRIC and the different statewide organizations and AAP that we have here, I think we could probably figure it out.
I sent Lizanne a
Yeah.
private text that just said, what if you did a handle with care bracelet or something that is easily recognizable by wherever that child goes, that you know that that's like automatically healthcare or whoever can recognize that that bracelet is associated with that.
Thank you, Dr. Hartman. What we'll do is bring some of your ideas back to the National Handle with Care group so that we understand the context of how other communities, I'm sure that other communities have bridged this and how they have bridged it in other states. And that's the brilliant part of this work. Every month there's a National Handle with Care call, and we can get on it and talk about what's happening in our communities and get feedback from other counties and states that have done this work. Thank you.
That's one thing I'll mention. All of the materials for it are free as well. So I'll just leave it with that. The one woman that got everything started in West Virginia made that a pillar of her work. So another cost savings for the program.
Okay, looks like the questions have died down a little bit. I guess, in the interest of time, let's move on. Josephine Mendy is the program manager for the Georgia Mental Health Access and Pediatrics program, which I am proud to be a part of. And I've actually been a member of the National Network of Child Psychiatry Access Programs for the past 12 years. So this is something that's near and dear to my heart. And so, Josephine, the floor is yours.
Thank you. Good afternoon. My name is Josephine Mende. I'm really excited to be here with you today. Just share my screen. Okay, and can you all see my slides okay?
Yes.
Wonderful. So today I'm going to be sharing a little bit of a little more information about the GMAP program. We heard Dr. Hartman mention about the GMAP program as well as Dr. Lukowitz. So I'm excited to just go a little bit deeper into what this is. So GMAP is an acronym. It stands for Georgia Mental Health Access and Pediatrics Program. For the purposes of this presentation, I'll continue to refer to it as GMAP. So today, what I aim to do is just to kind of provide an overview of our program here in Georgia, talk about some of the core services, give a quick review of years 1 and 2 of our award, and then end with future directions for our program. Some of the main takeaways that I hope to provide you with is an understanding of what is GMAP, what problem does it aim to solve, and what benefits do we expect to see down the road. So research is telling us that 1 in 5 US school-aged children have a mental health need, yet half are not receiving treatment. This is just in line with some of the data that Dr. Hartman has already shared earlier in her presentation. What we know is that there's a huge need, and by enrolling in GMAP, primary care providers can help to fill this gap by increasing their behavioral health knowledge or skill set. GMAP is a free program for pediatric primary care providers who serve children ages 0 to 21. This program is funded through HRSA, a 5-year grant from the Health Research Services Administration. And we are a 2021 awardee of this. So the really exciting news is that HRSA recognizes this need across the US. And so we are one of about 45 programs in various states and territories that are also working to address this need and to fill this gap in their states. What we've done thus far is deploy 2 ECHO training consultation teams across the state, starting in the Atlanta region, which is highlighted here as Region 3, and then Region 4 and Region 5 of the state. So that's going to be the southwestern part of Georgia, as well as the southeastern part of Georgia. We could not do this work on our own. I'm actually housed within the Center of Excellence for Children's Behavioral Health. And in my role as program manager, I really provide the day-to-day guidance and implementation of the program, as well as evaluation and backbone support for our partners who are doing the actual work. So I'll highlight some of the work that they're doing here. So in addition to the Department of Behavioral Health and Developmental Disabilities, our state behavioral health agency, and the prime for this grant, our other formal partners in the work include the Georgia chapter of the American Academy of Pediatrics, which we're really excited about this partnership and continuing to collaborate in this space. Another partner in this work is Children's Healthcare of Atlanta, which also happens to be one of the nation's largest pediatric healthcare systems. Through our partnership with Georgia AAP, we are also in partnership with Augusta University, the Medical College of Georgia, and Children's Hospital of Georgia, excuse me. This was a huge win for GMAP and for Georgia because it allows us to reach providers in the rural areas of the state. And it really allows us to tailor the program accordingly. Through our partnership with CHOA, GMAP has been able to expand some of our core services, which I'll highlight in the next couple of slides. We also have access to MindWorks Georgia. MindWorks Georgia, formerly known as the Interagency Directors Team, or IDT, was created by DBHDD to design, manage, facilitate, and implement an integrated approach to a child and adolescent's system of care that informs policy and practice and shares resources and funding. And the integrated approach is something that is a common theme, at least on the call today for sure. GMAP also hopes to integrate behavioral health care into the primary care setting. MindWorks Georgia is made up of over 20 representatives from state agencies and non-governmental organizations that serve children with behavioral health needs. So what this goes to show is that, we cannot work in silos, and just the strength of our partners that are in collaboration, working toward the same goal. What we really want to do is continue to leverage those relationships and to see who else do we need to invite into this work. Next, I am going to show a quick program video. I hope that the sound will play. This is a program video that just highlights the purpose of GMAP. This is something that we're using in our recruitment efforts as we're going out to speak with providers and speak to pediatricians and nurses.
The number of school-aged children with a treatable behavioral health disorder is increasing. Yet up to half of children in Georgia may not be receiving the treatment they need. That's where the Georgia Mental Health Access and Pediatrics Program, also known as GMAP, comes in. GMAP was created to increase pediatricians' expertise with treating mild to moderate behavioral health concerns in children ages 0 to 21, thus improving service for Georgia children and families and resulting in better health outcomes. At GMAP, we know you are the trusted primary care provider parents turn to for their children and teens. We also understand it can be difficult to assess, treat, and refer children with behavioral health needs in a timely manner. As a pediatric provider, when you enroll in GMAP, you will receive the tools necessary to serve children and families in need of behavioral health support. This includes access to a series of virtual provider education through Project ECHO, teleconsultation advice from experts, and access to a directory of specialized resources. Pediatric providers can visit GMAP's website to learn more about GMAP, register for upcoming training opportunities, and to enroll in the program. To enroll in GMAP, visit our website, select the Enroll Now button, and complete the form. Together, let's integrate behavioral health into primary care practice for children and families you serve. The number of
So this video just touched on some of those core services of GMAP that we offer, and you'll see some of those continued here. Provider education through Project ECHO, which we heard a little bit about earlier, but some of the topics that Project ECHO has currently touched on through GMAP is anxiety, depression, eating disorders, adverse childhood experiences, learning disabilities, and Georgia AAP and CHOA both continue to conduct continuous assessments in order to ensure that the topics that are being facilitated to providers that are enrolled in GMAP are relevant to meet the needs of what they need and what they're seeing. The second thing that our program offers is the teleconsultation advice line. That access line that Dr. Hartman mentioned is also a feature of GMAP. We're really excited about this. This is a provider-to-provider line that allows providers the ability to speak with the behavioral health expert to address patient care questions. The behavioral health expert that they're speaking with may be a child psychiatrist. Depending on the line that they call, it may also be an advanced practice mental health nurse practitioner as well. So this consultation line has really grown and expanded these past 2 years. So that's something that we really wanted to highlight. Right now, Georgia AAP is even piloting an advice line through their program, through their Project ECHO. And finally, the third core resource that we offer is the resource directory, which provides relevant resources for providers who are seeking services for their patients. We're working to build upon this directory. This is, it's really hard to build a comprehensive database. There are so many databases that exist, and providers are constantly coming in and falling off the map. So it's really key to keep this resource updated. So we're still looking into what is the best way to cultivate this resource directory. The next few slides are going to highlight some of the goals of GMAP. So I've kind of talked a little bit about what it is, how it came about, what's the usefulness of it. But we also do have some program goals that I just want to highlight for you. So one, we have a goal around our training in terms of implementing trainings to increase the number of pediatric primary care providers in Georgia who are trained to screen, treat, or refer children that are affected by behavioral disorders, especially those that are living in rural and underserved areas. That's one of the focal points of the GMAP program. The second goal that I'll highlight is the goal around the advice line, which is to provide support to the pediatric primary care workforce in Georgia through access to a regional pediatric mental health team, which then provides behavioral health consultations, referral information, and care coordination services. And the third goal that I will highlight is this resource and referral database that we're really looking to build and sustain in a comprehensive or online way so that this can become a resource for behavioral health providers in Georgia, for primary care providers who are wanting to have resources for their families. The next few slides are going to highlight a little bit about the data that we've seen so far in year 1 and year 2. We've just entered year 3 of the 5-year grant. So we do have some data, and we're excited to begin to see what is the need and what is the reach that GMAP is helping to provide, and where are there still gaps. So what you can see is 2 maps here. The first map really highlights the breakdown of the counties in which providers who are trained in GMAP through Project ECHO, where they are practicing. And then on the second map, highlighted ECHO year 2, what you can see is it's not a cumulative count, but rather we wanted to use this to show new providers that have engaged with the program through Project ECHO in the second year. Being able to pinpoint and identify the regional areas that our program is reaching is really helping us, especially as we're entering into this third year, to think about how do we intentionally reach those areas where we haven't had any provider engagement? What are the needs of providers in those areas, and how can GMAP support them? This next map is a similar map, but this just shows the reach of the consultation line. So just the advice line data is going to be highlighted here. What you can see is a comprehensive map of our reach throughout the state in year 2, this is. And what we see is a lot of activity in region 3 and the northern part of the state, not as much in regions 4 and 5, those bottom 2 areas of the state. One way that we're going to be addressing this in year 3 is through the pilot of the new teleconsultation line that is being offered through Georgia AAP, which we're really excited about because they have been very intentional in their outreach to providers that are specifically in regions 4 and 5 of the state. This slide also highlights some of the top patient concerns that we're seeing as people are calling the advice line. These are some of the typical reasons for the call: anxiety, depressive disorders, and attention deficit hyperactivity disorder. Additionally, the top reason for the consultation call is usually about medication management. So often providers are calling regarding questions, maybe medication has changed, or there are some issues around medication, so they're calling to speak to an expert who can advise them on what to do with the patient. In total, and over these past 2 years, we've had a total of 402 teleconsultation calls, and the number of times that providers have participated in Project ECHO is 259. And then our total enrolled providers to date is 114. So this just goes to show that, some providers are finding interest and finding utility with the advice line specifically. We have a lot of repeat callers who are calling in, they've sort of built this relationship with the advice line staff. They're able to call in and receive help on those de-identified cases that they're seeing in their offices. This is one way that we are aiming to increase access. Next, I'll spend a moment talking about future directions of this program. And this has really been broken down into 3 segments that we're looking into for the upcoming years: providers, uplifting the family voice, and then, of course, program sustainability. One of the focus areas, of course, is providers. This program is targeted for providers. So we want to find out what are the key benefits and what do they really need? What can GMAP do to support them? And how can we engage with them? One of the needs that we heard is Project ECHO education trainings around self-care and stress management for providers. And so we're excited that in this year 3, CHO is going to be exploring Project ECHO topics around those topics. The second thing that we want to highlight is uplifting the family voice. We know how critical it is to hear from those with lived experience and how that can be so useful in shaping the program. So what we're wanting to do is to capture the family perspective and see, are there examples and ways that families have been impacted both positively or negatively as a result of some of this work? And what are they needing? What things do they need in order to live healthy lives? And finally, sustainability. So far, we have been able to share some of this progress with our stakeholders, and we've also been able to share this progress as a way to reach out to new providers who've not yet heard about GMAP or who are not connected to this program. We look forward to expanding the teleconsultation line further. So right now, I mentioned that we have a second hub essentially with the Georgia AAP. We are wanting to explore what would this look like, or what would it take for this to be expanded statewide? How can we create and sustain a statewide access line? One state in particular that's done this really well is Virginia. And so we have used Virginia as sort of a model hub of how they are going about their regional line. They have about 5 regional lines for different regions in their state. And you know, we right now have 2. And so what will it look like to sustain this into the other parts of the state? And finally, we are interested in onboarding additional GMAP sites. There are places in regions 2 and regions 1 that we've not yet integrated. And so we are wanting to get connected to providers, to healthcare organizations in those areas so we can begin utilizing these program services in those parts of the state. So some of my main takeaways again were, you know, what is GMAP? What is the problem that we're seeing, and how is GMAP aiming to solve them? And then what benefits are we expecting to see down the road? Now we know that GMAP can only do so much in terms of, you know, helping expand and increasing access to providers. And we know that more is needed, but I hope that this presentation has been helpful in just providing a little bit more information on what GMAP is. And I hope it's helping you think of ways that we can collaborate with you in bringing this program statewide. For more information, you can scan this QR code or visit us online. Thank you for your time. And I am happy to answer any questions.
Has there been any interaction with the psychiatric residential treatment facilities for children in Georgia?
We have not yet had any interactions with them.
I think that might be, we get a lot of calls where people, doctors calling, looking for resources. That might be a good connection.
So I've been part of the consultation line, and I've done echoes as well, a number of echoes, and we're actually getting ready to pilot some new echoes for ADHD, which is one of the things that I thought we needed, and the AAP has agreed. It's been a challenge to get providers in regions 4 and 5 to sign up for these echoes. Have any ideas on what we can do to reach those people? Because I mean, I look at the number of child providers in those areas, and it's hardly any. So I'm not sure if for some reason the message isn't quite making it to them. And I was looking at the numbers, like there's like the Southeast and Southwest in Georgia are always the least amount of providers. Like, for example, Chatham County has 7 child psychiatrists compared to 57 in Fulton County, 53 in DeKalb County, and 18 Cobb County, and 12 in Gwinnett. So obviously, like, the vast majority is in the metro Atlanta area, but the areas that need the most access are other parts of the state. And it seems like we've had a hard time penetrating that area, and there seems to be a need, but the message doesn't seem to be going out. I'm not sure how to fix that.
Having worked in Southeast Georgia, Donaldsonville, specifically Seminole County, for 7 years, I can tell you that the message that it's available is probably not out there, or the echoes aren't being offered at a time that is convenient for those people. In the rural areas, you're often the only person. I was the only pediatrician for 3 counties. And that means my workday went from 7 in the morning till 6 or 7 at night. And so if something was offered on a Saturday or something, I would probably do it. But during the week, you could forget it, because in addition to having the clinic, I also had to round in the hospital. I had to go to the nursery. I was the only one. And so I did not have time for some of the things that were offered that would have been helpful. I just didn't have time to do them.
What about 5:30 p.m.? Do you think that would be, because that's one of the things we've talked about possibly doing, but you don't think that would work?
Clinic didn't end till 6 o'clock most days. I mean, because you're it. And so you're not going to turn people away. If they come into the clinic sick, you're going to see them. And so very rarely did I finish before 6 o'clock most days.
Okay. And the other thing, you mentioned something about the plan to integrate behavioral health into primary care. Was there anything specific that you had in mind? Because I was very interested in that as well.
So one thing that we're seeing is that the integrated approach is really the gold standard. It's really the best way, the one that Dr. Hartman mentioned, where there is someone there in the office. And, right now through GMAP, that's not always feasible. But one way that we're looking to do that integrated approach is to maybe increase the way that the telehealth is done and what that looks like. As an example, another state is doing, they have actual teleconsultations that are done with the patient and the provider to the advice line staff. That makes sense. So the patient and the provider are together and they are now consulting via the access line, and that becomes almost like a face-to-face consult call. So I think that's one way that we can kind of integrate it.
Well, again, thank you so much, Josephine. And let's, again, in the essence of time, I want to welcome Wendy T. Green, who it turns out we have a common friend from our youth. And so she was my anatomy partner in medical school and one of the finest people I know. So and with that, she is the director of the Office of Medicaid Coordination and Health System Innovation for the Department of Behavioral Health and Developmental Disabilities. So Wendy, welcome, and the floor is yours.
Thanks, Dr. Lukowitz. And yes, one of my best friends from college was a colleague of yours. So it was so funny to make that connection just recently. And I'm really delighted to be here with you guys. And it's been awesome hearing all of you as we've moved through this. Today, Dr. Hartman, hearing you talking about 988 warms my heart as one of the leads for that for the state. Hearing you talk about Apex, which is something that I work on extensively. So excited. And I think most importantly, one of the things that I think is ever so crucial is you talked about the need for enhancing the reimbursement rate for behavioral health services. Pardon me one sec. Thank you. And that is essential. And that's what I'm here to talk to you guys about today. So I'm just going to convert this to slideshow view. If someone could give me a thumbs up that you're able to see that. Okay. Great. So we have a rate study underway for the state. And when I say the state, there's a few things I want to kind of talk with you about, which are parameters for what I'm going to talk to you about today. So all of you, I think, know from my introduction that I work for DBHDD and I work in the Office of Medicaid Coordination, which means that I work from our department's level, working with the Medicaid Authority to be sure that we are coordinating a shared benefit related to kind of the public sector mental health benefits for those with the most kind of critical conditions. So SMI for adults, or the term SPMI, and SED for young people, particularly those who have some, complex issues, multi-system involvement and the like. So we are in the middle of
excuse me, Wendy, part of your screen, at least I'm seeing, is blocked by a note at the bottom. I think you're in presenter mode.
Okay, let's see here. Bear with. It didn't give me a choice, so I'm just going to stop sharing for 1 sec and double back in. Let's see, let me try. Usually this doesn't kick me to this mode, so I'm going to go to display settings and see if I can. And it may be because I'm on multi-screen, so
Yeah, multi-screens will cause that.
yeah. So I'm going to pull out of that for 1 sec. Okay, team, is that looking a little bit better?
I can't see anything right now except you.
Huh, okay, hang on. I apologize for that. It's the curse of too much technology in this case. So I'm going to kind of be talking this out loud while I'm going, just so that we are expediting our time, because I know I'm kind of rounding up the back of this here. So let me just reset 1 moment. Okay. How is that looking, guys?
Perfect.
Yes. Okay. Awesome. So my apologies for, like I said, too much tech. So the behavioral health rate study then is targeted on kind of shared programmatic work that DBHCD and DCH do together for kind of the most intensive public sector populations. And very specifically, I want to kind of set a frame and a scope here. So this is for fee-for-service reimbursement. So when DBHCD kind of has a contract network, it's a program called Community Behavioral Health Rehabilitation Services under Medicaid. So a unit of service is provided by a qualified provider agency, and then it's reimbursed on a fee-for-service basis. That's very standard. It's a program that we co-manage with DCH. So I think a couple of things important to note here is that DBHDD holds the state match money in our budget for the Medicaid dollars. So very different from like if you were talking about like a pediatrician doing Medicaid practice in Georgia, that money, the portion that's state money that has to be put up for federal match for Medicaid is in the DCH budget. In this particular program, the money is in DBHDD's budget. So when you hear like Medicaid talking about that they are asking for like growth money in their budgets, this is never like talking about this program because all of that money is in DBHDD's operating budget. And DBHDD right now sets the policy and practice guidance for all of these services. Now, when you're talking about a rate change in Georgia, you have to go through federal Medicaid. So you have to talk to them about what your process is for setting rates, and they have to approve it. And they use the term that they have to be actuarially sound, with an actuary being an insurance practitioner who is uniquely certified to assess what the cost of services are and to predict what the reimbursement should be related to that service. So when I'm talking today, these next few slides, a couple of things to think about in terms of things to exclude in your minds and things to include in your minds. So this excludes CMO rates. So when you're talking about like Peach State and AmeriGroup, what I'm talking about here does not impact that directly. Indirectly, it does. So if the Medicaid agency sets a unit of individual therapy to be $100 an hour, and the CMO pays $75, well, that puts some pressure on them to adjust their rates to be kind of in market. So that's kind of an indirect example of impact. But just because we say a rate will be $100 an hour, the CMO does not have to adopt that. They could pay more, they could pay 110, or they could pay 90, or they could pay nothing near the rate. And that is actually allowable in accordance with that unique plan. The PRTF rate is separate. Now, DBHTD does manage that budget as well for state match, but the PRTF rates are not what I'm going to talk about today. Good news is the PRTF rates were just voted for approval for a rate increase last week. So we're really excited about that. I'm sure Gwen is really excited about that. And so we've been partnered on that, but that's not what I'm going to talk about today. And this conversation does not apply to pediatricians or standalone psychologists, autism providers like BCBAs. This doesn't talk about that. So there's a lot of behavioral health services Medicaid covers that this does not apply to today. This does include the behavioral health services that are offered by community service boards. It includes things like assertive community treatment providers, peer support providers like certified peer specialists who work in agencies, intensive family intervention, which is like an in-home intensive child serving model. And it includes some crisis stabilization unit services. So 16 beds. And by the way, our fire alarm just went off. Oh, they said they're just testing it, but I'm really sorry if that just came across the screen. I'm at the Twin Towers, and that's like, okay, very interesting, folks. I hope that wasn't too intrusive. So my second slide here is just kind of the context for what's going on with this rate study. So the study is well overdue. The last time we changed rates, I think Gwen Skinner might have been the commissioner director of our agency. So this is kind of sad to report then, right, Gwen? 2008 is the last time we adjusted rates. And that was based on wage and labor statistics that were marked in 2007. So that's kind of a sad state of affairs when you think about how wages have grown. We do have to get support from the legislature and executive branch before we do rate studies. We did have to do one for the ADA settlement, but it was always left in draft form and it was never adopted. For CSUs, the rate is based on 2003 data. So even older, we're at 20 plus years on when that rate was last revisited. And of course, we've had a continued behavioral health workforce crisis since that time. I began using the workforce crisis map from HRSA beginning in 2008. So we know this is well overdue. So in the middle column, HB 911, which was the Appropriations Act for FY23, in effect, green-lighted doing a rate study because it gave us money to complete it, which was then in some ways an endorsement of, yes, it's time for us to do some significant rate adjustment. And of course, our partner is DCH and Deloitte on this whole issue. Deloitte is a certified Medicaid actuary, and so they were our partner in this. And then the final column in the box in terms of context is for what's called ARPA. which many of you probably have remember from COVID-19. Congress passed the ARPA law, and within it, there was a unique section called Home and Community-Based Services. And it laid out a money pathway for us, for Georgia, to capitalize on some bonus funds from Congress related to COVID-19. And so if you're not familiar with that, I'm going to just do 60-second tutorial, which is, here's just the description, but basically what it said, for every dollar spent on particular types of services, it would give the state 10 additional cents for every one of those dollars for particular services. For the first time, the Congress identified that the rehab option, the Medicaid rehab option for mental health and addiction, could be considered a home and community-based service. So that's not common, but this was, again, crisis times. And so mental health was considered almost like a waiver service for IDD. It was given like a different lens for this initiative. And if you think about 10 extra percentage points for every dollar spent in Medicaid, what we ended up with is kind of what I call a bank, or I've labeled here as a yield or a holdings account. And for the Medicaid rehab option, what is sitting available to us right now is $14.5 million waiting to be released. And so, again, ARPA is sitting off to the side, but it is crucial for this dialogue, because what we know is that having this money available gives us a running start on raising these rates. So we had to submit a plan to CMS to tell them how we would spend it. And we said we would do it for a rate increase, and that was approved and is locked in with federal Medicaid. But CMS came back to the state and said, thou shalt do a formal rate study, which supported what was in the middle column. And it said that you have to have a sustainability plan, which was awesome, right? I mean, from a funding perspective, to have a green light to say, okay, in order to start this money flowing, we have to have a state game plan for sustaining it. We had originally talked to CMS about having the money flowing by January of 2024. We're not there yet, but there is a deadline for spending them. So they have to be spent by March 31st, 2025. So we have a little over a year and a quarter then to spend these funds. So we entered into this process, right, of doing the rate study, and it's been a long journey. So we had that charge from the legislature in spring of 22. We engaged with our actuary. We did the actuary orientation and policy finance study. We moved all the way through the study process, which included providers submitting tons of data, new wage and labor statistics review content. Findings were presented over the course of May and June. There is a DBHDD website for this, a whole site that says behavioral health rate study, if you're geeking out in some way and want to dig deep into that. And then you see a series of question marks here, which is we have to have leadership endorsement for sustainability. So that means executive support and legislative support to have an appropriations that would support a rate increase. And then we move through all this technical stuff, which is DCH's board has to approve. There has to be a hearing. There has to be a second board approval. It has to go to federal CMS. Then we start working on their approval. If there's their approval, IT changes. But the big question, the triple question mark here is we have to have state funds to serve the indigent. So DBHDD serves tens of thousands of folks who are uninsured. So we have this ARPA money, $14.5 million, that can get us started on Medicaid, but we have to have a commensurate state funding package for a rate increase for the uninsured. So those are dialogues that are underway about how that might happen. Again, we've got this deadline, March 31st looming, and we have to have a sustainability plan to CMS if we're going to use a dime of that money. So we had kind of a big leadership group who helped on this, designing this process. We had a core leadership group from providers, 16 providers who helped guide us and what the survey process would look like. And then 60 providers provided data and information to feed the process. We looked at all kinds of detail that you would think goes into a cost study and report. And so I'm not going to hover here, but you see just their fundamental things that go into kind of any Medicaid rate setting initiative. For public sector, I'll just share that like things like productivity, which you see in the middle of the chart. When you have a lot of federal fund sources and a lot of reporting requirements, productivity is lower because you're gathering tons of data, tons of information. You're going to sit in courts. You're sitting in the schools for Apex, right? Your productive time diminishes. So things like that were all taken into account. Here are some rate methodology decisions that we used. Just again, this is more service centered. So I think from a policy perspective, these are things that are helpful for you to know, but I'm not going to spend a lot of time hovering here. But basically where we kind of came to is looking in total that it looks like we are needing about a 33% rate increase when you consider calendar year 2019 implementation, looking at new rates compared to calendar year 19. And we used that, and I've highlighted that because when you look at state fiscal year 2022, you can see that we're still in recovery. We've lost a ton of workforce. We have a ton of vacancies. And so we are moving ahead as if we are still in recovery mode and will continue to be in recovery mode post-pandemic. Here, I just want to share a few pieces of information about what this will mean for practitioners. And again, we can't always guarantee that agencies are going to pay practitioners the way you see here for the 2008 process, or that they will pay folks like this in the future. But when you look at the labor and statistics information across the country and then unique to Georgia, you can see we need significant improvement. And I don't know of a physician, folks, who works full-time for $160K, which means our system has been bleeding on this for a long time. And then when you look at the middle bracket, which is LCSWs and RNs, that all fold into one category. Again, there's not an RN out there working full time for $48,000. So we have been hurting for a long time, which constricts growth, which then constricts access. And so we are not completely enamored with the future rate salaries, but they look a heck of a lot better than where we are now. To the tune of 33% better. We did do research, and Starbucks baristas are making more than our certified peer specialists who are down in the bracket at the very bottom. So, and it's a much easier job. So we have been, I think, in a really challenged situation for a while that we're now trying to correct. So again, you see that's a 33% increase. You see that what we need going forward for the Medicaid rehab option is 17 million on an annualized basis. For ARPA, we have 14.4 million banked, so we can kind of get through several months of this as a kickoff. So we probably would need limited funds for fiscal year 25. but more funds annualized, we would need that 17 million annualized. But then underneath, you see for the state funded folks, for the uninsured, we would continue to need 22 million on an annualized basis. And so finally, really next steps here, we are working with the governor's office, the Office of Planning and Budget, and DCH, and we are projecting, okay, well, if we went live in April, what would that look like? If we went live next July, what would that look like? So we're doing these projection exercises to help try to figure out how much money would be needed in which fiscal year budgets. There's a lot of considerations. A lot of rate studies happened at the same time for DCH. So there's a big pull on the system on whether or not they can implement multiple rate studies all at once. CMS will have to review and accept the new rates, which is pretty much assured, given that we've not raised the rates since 2008. I think they're going to be like, yeah, please. And then we have to do technical implementation. So that is about as fast as somebody can report out on a massive multi-million-dollar rate increase, but we really wanted to bring that here. Dr. McGivney and I started conversations in May about access and why access is hampered. And I was like, Dr. McGivney, like, access is hampered because of these rates. And it's been graduated, right? So I think with every year that goes by and you can work at other places and you can make more money other places, it just has created this kind of critical vice around the system that we really need to take the opportunity to shake free as a state at this point. So we wanted to bring that here to you today and share where we are and share that there should be probably a lot of dialogue in the next few months about whether or not this is going to move forward. And we felt like it was a good time to be in the sharing space with all of you. Questions?
Yeah, so this is wonderful, and a perfect example, and this is something that Kevin Tanner brought up here in Augusta, and I always complain about the abysmal services that we have here in Augusta, but Serenity Behavioral Health has a crisis stabilization unit, which was 16 beds, but because of the inability to staff those 16 beds, they only had access to 8, and so
Right.
now so this is really critical. And they're planning on expanding to 32 beds. Now they've actually expanded some, but we're not there yet. So this is really critical in order to keep people in the positions to be able to treat patients.
And I will share again, I just want to point out, like on the CSU item, that with Medicaid, you can only bill when you are 16 beds or less. So we're going to be investing in Serenity state money for them to grow. It's just a choice we're having to make at this point. We need more beds, and building a new 16 bed space, it just doesn't really get offset by the Medicaid rate. So there's the IMD rule that is in Medicaid law that prohibits Medicaid billing if you're greater than 16 beds. So it's not uncommon. We've done this all over the state. We've had to. It's just a decision point that states have to make. And in terms of what's practical and what's efficient and effective in terms of funding these facilities. So Serenity can bill now, but right now they're billing $210 a day. The rate design says they need to be billing $869 a day. That's 4 times more.
So the increase, Wendy, is for both child and adolescent crisis stabilization as well as adult?
Yeah, and for also for individual therapy, and also for group therapy, and also for family. All of this is for youth and all age spans for adults.
So that's great. Is there any plan for increasing the number of CSU beds?
That's a completely separate plan, Gwen. Yes, and our budget request for this year does ask for more CSU expansion. And I mean, our budget's published online, but I have a unique slide being part of the 988 chairmanship. I kind of have a targeted slide with just the someone to go, someone to call, and the somewhere to go detail that I can send as a separate item tag just to respond to you when I send these slides.
That would be nice. Thank you.
Yeah, and we were blessed with 24 million last year. So, I mean, we are really grateful to the legislature for continuing to fund critical elements of our system, but this one has lagged entirely too long. It's hard to defend, you know, salary reimbursement rates that are based on 2007 wages. It's really difficult.
Wendy, it's David Bradley here. Thank you so much. I'm new to the commission and new to this committee and trying to wrap my head around my little sidebars. I'm doing a lot of studies just to figure out what the acronyms are. So I'm getting there. But on the rate changes, how does that correlate to surrounding states and things? I mean, are we in the ballpark with the new numbers that it would be attractive for a practitioner to move to Georgia?
With the new numbers, yes. Yeah.
Okay.
Yeah, we actually looked at what we called regional lenses of other states who do like services. And then we looked at other states, non-regional, who really look like Georgia, right? Like who have like traditional community providers like our community service boards and have super comprehensive benefits like we do. So we chose a regional study. And then we chose this this national scan for states that were like look like siblings or like sister state models, so that we could look at comparisons there. And we did slight adjustments on particular categories where there were issues such as that. And for instance, if you deep dive into any of the data that's published online, like we had to do a little bit more than wage and labor stats for the lower two categories, because we are losing those folks. When we looked at productivity data from our providers, we're losing them because they're just like, you know, either GED high school level, bachelor's level folks, or some college, and they can go work as an insurance adjuster, or they can work, you know, at a car dealership.
Right.
They have more portability and will take advantage of more portability and leave our system for their kind of personal financial growth. And so when we looked at vacancies across the board, we are getting the most rapid turnover in those two categories, even though you can get much more competitive wages at these top levels of practitioners here. They're at least kind of bound into healthcare in most cases. The lower brackets, they're like, I will go where the money goes, and we're just going to leave behavioral health altogether. So we had to do a little bit more of an adjustment to try to keep competitive employment there.
Okay. Besides just the rate, and I know it's getting late, but besides just the rate, are there other benefits that we're competitive with? I mean, from a health insurance side, those two lower levels there with that earning number is universal across all jobs. I mean, those are the ones that are more portable and the ones that are going to jump ship as soon as they can, unless there's something sticky enough to keep them there.
Yeah. So we did look at we had to look at the benefit packages, and so we had a range of ways providers pay for this, right? We have some part-time employees who are getting no benefits, but we included things like PTO, sick leave in like these benefit packages and made them a percentage of salary. So while you see a salary here in our ultimate categorical review, we looked at all of the employee related expenses. So you see the second row right here. We did the whole benefits, training days, PTO, all of that, and cost that out, which was then an add-on to those base salary items that you were looking at.
Okay, thank you.
So a Medicaid rate then, David, just quickly, ultimately will not be that salary divided by a number of widgets. It is that salary is one part of a formula that includes all the things on this slide.
I was talking. Thank you.
Yeah, you're welcome. Anything else, guys?
This
And
is,
again, you can geek out all over DBHCD's website. And it's funny because there's a video of a training we did, and you know, the little YouTube start button that's red is right in the middle of my nose. So you can have a good laugh on me because I look like Rudolph.
well, this has been really a wonderful explanation of a very complicated process. And I really appreciate you providing this with us, because I don't think I could have digested it by myself without your expert guidance. But I'm thrilled to hear that at least we have a proposal to increase salaries and bring back people to the behavioral health workforce. And hopefully the powers that be will see fit to fund that going forward.
We're really hopeful, and we assume it'll be part of kind of the emerging dialogue over the next few months and weeks for the system.
And I'm sure Commissioner Tanner will do his part from the behind the scenes to try to encourage support. So I have complete faith in his ability to accomplish it.
Yeah, no doubt about it. I'm doing a lot with him on it right now. Yes, he is. And yes, I am.
Wendy, have you spoken to the mental health policy partnership about this so that the advocates can get behind this?
No, if an invitation's extended, I would not say no to it.
Well, I'll work on that. Also, have you or would it even be appropriate to talk to the mental health caucus? That's a little, that might be a little tender there.
Well, I mean, I think all kinds of people ask Commissioner Tanner for different presentations and that type of thing. So whoever asks for that from him, however I can deploy, I'm deployable.
I had the opportunity to talk last year, and that's something that I'm not part of the state government. I mean, I am technically, I work for the University System of Georgia, but this is unrelated to DBHDD, and certainly can yell and scream like the best of them. Well, thank you so much. This has been a wonderful session, and I appreciate all those of you who participated today for enlightening us and helping us move forward in for a child and adolescent behavioral health here in Georgia. So I don't remember, we do have a meeting next month, but it'll be the fourth Thursday of the month at the same time. So again, thank you all for coming and presenting and for listening, and have a good evening.
Thank you.